pleased in our continued tradition of our chief residents giving the talk on the topic of their choice. I'm pleased to introduce Dr. Hinchcliff, who's on her way to a hand fellowship. And we look forward to thinking about ways to involve you potentially in the future. But we look forward to the lessons you've learned in residency.
Thanks, Dr. Farmer, so much for that introduction. I'm Kate, as many of you know, and I'm a chief resident in plastic surgery. And there were a lot of times in the past few weeks that I thought I probably wouldn't make it to this talk, so I'm happy to be here. So I have no disclosures, except for that these lesson slides that I'll present are level 7 evidence only, meaning that they're based solely on my opinion and not on any data at all. So when I was looking to choose a topic, because as Dr. Farmer said, we can choose our own topics for this talk, I thought back to advice given to the medical students that rotate through our service, because they're all asked to give an end of rotation talk on our Grand Rounds Day. So some of the advice I usually give is to give a talk on a topic that's interesting to you, but also to your audience. Stay away from exhausted topics. We talk a lot in plastic surgery about fat grafting, and so when we get a talk on fat grafting from a medical student, most people just like tune right out of it. Make it case-based. You know, we're all surgeons, so I think we get a little more interested when there's a case or a patient involved. And for plastic surgery, if you have pictures, that's also really nice. And then if you can, make it a little bit personal. You know, it's not the time for like a grim life story, but it is the time, you know, you've been on the service for a month, everyone kind of knows you a little, and if you can share something that makes us feel like we knew you a little bit more, then I think that that's really cool. So for my grand rounds, I'm going to discuss a case where we performed extracorporeal perfusion of a free flap. I'll discuss indications, how we arrived on this operative plan, and background data relating to extracorporeal perfusion. I'm going to review the intraoperative and postoperative course for this patient, and then future directions for extracorporeal perfusion. And then interspersed within the talk will be takeaway lessons that I learned from this case, but also from other residency experiences. And with these slides, it's not my intention to create like an exhaustive list of lessons, but to kind of keep it to a few pearls that I thought were relevant to this case and that would be maybe useful to some of the younger residents or medical students in the crowd. So this is a patient, she's a 74-year-old lady. She presented to Marshall Hospital with a pathologic fracture of her right femur. At that hospital, she underwent tumor debulking, biopsy, and an IM nail via a lateral approach. Her pathology came back as dedifferentiated chondrosarcoma, and she was referred down to UC Davis for care by Dr. Thorpe and Dr. Bain. You can see her MRI, the post-nail MRI, still has tumor within the femur and in the soft tissue of the hip adjacent to the nail entry site. So for my first lesson, I wanted to talk about finding mentors. And Dr. Bain, whose case this was, has been an important surgical mentor for me. And so this is the first lesson that I wanted to cover about my experience with surgical mentorship and finding mentorship in residency. With respect to surgical mentorship, I really don't think it applies that much to the first 2 years in residency, because during that time, you're learning how to operate, but you're not really learning how to command an operation. You know, the larger task at hand for those first 2 years is just to figure out what makes a good surgeon. So how do they talk to their patients? How do they prepare for cases? How do they act in the OR? All those things are done mainly through observation. So what you really need during that time is a role model. A role model is someone that's defined as someone you identify with, who has qualities that you would like to have, but it's observational. So for example, Dr. Wiedemann, who's in the crowd, and Dr. Stark, who's now up in Oregon, or Seattle rather, were really important surgical mentors to me, surgical role models to me the first couple of years, and they shaped the way that I practice surgery, but I wouldn't necessarily call them mentors. And I wanted to include a picture of you, but you've kept your online presence very small, so good job doing that. The word mentor, on the other hand, is derived, as many of you may know, from Homer's Odyssey. So mentor is the name of a friend of Odysseus who, when he went off on his travels, he left his son Telemachus in the care of this guy to teach him and raise him. So it implies a certain level of friendship, or at least relationship, and trust. So when I think about like who would be a surgical mentor to me, the way I judge it is sort of by the 2 a.m. litmus test, which is to say, you know, in a year and a half when I'm in my boards collection period and it's like the middle of the night and I'm doing some trauma case and things went way off script, who am I going to call and who would pick up a call from me? Like that person is your surgical mentor. And so to have that person to call, it really implies a commonality in surgical practice, trust in that mentor's surgical decision making, and also trust in their knowledge of you as a surgeon and really what you can do, and that they're not going to tell you to do something that like your body can't cash. So it makes sense that in cultivating this mentorship, it starts with you. It starts with the trainee by identifying a surgical role model and then seeking them out for cases. When you are doing that, as Dr. Farmer actually alluded to with this last M&M, it's important that you talk to them preoperatively about your plan for the patient, their plan for the patient, both to figure out how they think and get some of that surgical decision making, and also so that they can see how you think and help you work through that process. And then ideally over time, the mentor starts to know about you and where you need help, and then ideally that relationship becomes more of a two-way street. So back to the case, the patient was recommended by Dr. Thorpe to undergo a right external hemi-pelvectomy with curative intent. For those who don't know, an internal hemi-pelvectomy is a limb-sparing pelvic resection, and then there's different types depending on what part of the pelvis you take out, versus an external hemi-pelvectomy, which is also called a hindquarter amputation, and removes the entire lower extremity with the pelvis. Closure of the defect after an external, oh, that's so nice, thank you. Take a sip. So external hemi-pelvectomy is usually closed with a local soft tissue flap, an example of which is in this picture. But our patient couldn't have that done because she'd had the prior tumor resection and seeding into the local tissue from that resection, and then also from the tumor itself. So an extensive soft tissue resection was required, and there was no local tissue available. So a described reconstructive method to deal with the situation is also known as a spare part surgery, taking a free fillet flap from the leg based on the below knee popliteal vessels. So you can see in this picture, the flap harvest is accomplished through longitudinal incision. Longitudinal incision in line with the tibia, and then a circumferential subperiosteal dissection around the tibia. The fibula gets cut at the ankle and then dissected out, although most surgeons will leave the top portion of the fibula to avoid having to dissect around the peritoneal vessels. But you have to cut out the bottom part because otherwise you risk flap perforation with the bone, which is the way that we did this dissection. After the flap is harvested, the planned recipient vessels are the external iliac artery and vein, which you would have to then get to, if you think about it, after hip disarticulation. So the issue with this plan, or something at least to think about, is that it obligates a long ischemia time because you have to harvest the flap, but then complete the disarticulation and repair your recipient vessels. So ischemia time for flap surgery can be an issue. Long ischemia times decrease flap survival through direct ischemic injury, for which muscle flaps are more vulnerable due to their higher metabolic demand, and also through reperfusion insult. Long ischemia times are not common, but they do happen in flap surgery. Other reasons you might have it would be need for a position change, unanticipated issues with your recipient vessels, need for a vein graft that you didn't think you had, or in our situation, need for a interval hemi-pelvectomy. So in this case, in discussing this problem with Dr. Bain, I sort of was thinking, well, there are probably other times in my residency that I've seen a long ischemia time. And some of you may know where this is going. So hypothermic machine perfusion is well established and used on the transplant service for organ preservation, specifically in our institution with renal allotransplantation. While the standard of care is still static cold storage, as Andrew's talk, I don't know if Andrew's here today, but as Andrew mentioned in his excellent Grand Rounds talk for us, machine perfusion leads to decreased delayed graft function and improved graft survival. So having some experience using the kidney pump in the past, I thought, well, perhaps using it in this circumstance might help mitigate some of the effects of a long ischemia time. The theories on the mechanism behind the benefits of machine perfusion largely come also from the transplant literature. I just thought it'd be helpful to go over the pathophysiology here a little bit. The most important mechanism to discuss is probably the fact that cessation of flow causes endothelial damage, leading to endothelial swelling and vasospasm. And so if you can keep the flow going, that is prevented. Interestingly, pulsatile flow is more protective to the endothelium than non-pulsatile flow, so there's a little bit more to it than just keeping the vessel open. But if you can decrease small vessel damage, you can improve the microcirculation to the graft, and that's going to lead to higher overall flow in your graft. Also important is that machine perfusion can eliminate ischemic waste products. That can help the graft, but it also has bearing to our case, because if you can, we're taking pretty much the whole lower leg muscle and reanastomosing it after an ischemia time. So if you can get rid of the ischemic byproducts that are sitting in the flap, that's going to limit your need to let the vein bleed after reanastomosis. So, in discussing this idea with Dr. Bain, he was generally sort of game to try it, but very reasonably said that I should show him some literature on flap perfusion and not just kidney perfusion, which makes sense. And as almost always the case with any novel idea, this idea ended up not being that novel because there's actually a decent amount of literature on extracorporeal flap perfusion. The first reported case of it is by Cooley et al. In 1990. This is a lab study where they used a rat model and free groin flaps from the rat, which again are, they're not muscle flaps, so their ischemia tolerance is higher. They did a 30-hour cold storage of the flaps followed by replantation and looked at flap survival. And they found, and their control group was just static cold storage versus the experimental group, which was hand perfused halfway through their ischemia time with anticoagulated whole blood. And they found pretty impressive results. A 92% flap survival in the perfused group versus 8% in the control group. So they concluded that anticoagulation with whole blood improves chances for viable reperfusion after an ischemia time. There's actually been a lot more recent animal studies regarding extracorporeal flap perfusion, but in the interest of time, I'm going to present this one. Their outcomes were not flap survival, but they did discuss, their outcomes are looking at proteins that are affected by ischemia, so I think it's useful. In this study out of Germany, they used porcine model rectus flaps because the anatomy is similar to that of humans. And the purpose was to investigate whether extracorporeal perfusion could change the expression of these two proteins, Capsase 3, which is pro-apoptotic, and hypoxia-inducible factor 1-alpha, or HIF-1-alpha, which are found in tissues adapting to ischemia. So there were 4 experimental groups here, which I'll go over, and they compared biopsies of the muscle at 15 minutes, 30 minutes, and 60 minutes to a baseline amount of each protein. So in the cold storage group, they found increased amounts of all the proteins at every time point. And with a single heparin flush, which is our standard of care for flaps prior to undergoing ischemia time, they also found increased amounts of the protein. However, in the perfused whole blood group, they found increased amounts only at later time points. And then with perfusion solution, they only found an increase in Capsase 3 at 60 minutes and no significant difference in the other protein amounts. So they concluded that perfusion may be protective against ischemia. And sort of interestingly, in respect to the perfusion solution, they thought that probably the whole blood did worse because it wasn't oxygenated, so maybe there was a buildup of ischemic metabolites. There are some case reports as well regarding extracorporeal flap perfusion. The first one was by Newsom et al., and this was actually a case similar to ours. It was a patient undergoing an external hemi-pelvectomy, and so they took the amputated limb and then perfused it on ECMO, as you can see in this picture here, while they harvested an ALT flap, which was raised and then put into the defect. Another case by Traeger in 2016, perfused a latissimus flap with perfusion solution for 49 minutes during a position change. I want to show this picture of their setup because it's pretty simple. It's just a cannula attached to an infusion bag with one-way flow that went at a continuous non-pulsatile rate. Both flaps did well with no flap-related complications. There's also one case series existing for extracorporeal flap perfusion by Fitcher et al. In 2016. They used a custom-built perfusion device and oxygenated heparinized whole blood as their perfusate. They temporarily perfused 8 radial forearm flaps, which were all, they put the flaps on pump if they thought that the ischemia time was going to be over 2 hours, and there were various reasons for needing a long ischemia time. One, arterial thrombosis. 2, these are neck surgeries, so often these patients have been radiated, the recipient vessels are not what you thought, there's a need for a vein graft that you didn't expect, and other reasons. But the longest ischemia time that they had was about 4 hours. You can see in the picture, they did indocyanine green or SPY imaging of their flaps during perfusion, and they had excellent flap perfusion the entire time. This is just a picture of the cute little flap hooked up to the perfusion device. And then they compared their results to 30 flaps that didn't undergo perfusion and found no difference in flap survival, complications, or length of stay. So armed with this prior literature, we decided to proceed. Based on the literature and also on availability, we used University of Wisconsin solution as our perfusate. This is an isotonic solution that has large colloids to prevent third spacing. It includes ATP substrates, insulin, and free radical scavengers. And we added heparin to it at a bolus weight-based dosing of 70 to 100 units per kilogram, which is kind of the heparin bolus we would give someone prior to free flap transfer. For the perfusion pump, we considered hand perfusion or a cannula infusion bag setup, but decided to use the kidney perfusion pump, 1 for better regulation of flow and pressure, and 2 for the ability to provide pulsatile flow, and then also because it was available to us. So this brings me to my second lesson, to not reinvent the wheel. So one aspect of all these papers, both the animal models and the case reports, is that they use a de novo designed perfusion pump. And this is not a commentary on the effectiveness of one pump versus another, because maybe one of the pumps that was designed is better or more efficacious. This isn't a comparison, but there are some benefits to using a commercially designed pump that I think apply more broadly to residency. You could probably also have titled this slide, to know your resources. First off, knowing and using the resources available to you can greatly increase productivity. Creating a perfusion device takes a lot more time and effort than using one that's already ready to go. And I think that like everyone in this room probably has had an experience where they had a research idea or a clinical idea that they really wanted to get off the ground, but depending on resources available, they felt that you couldn't do it. And then the idea never goes anywhere. So really exploring what's around you, including in other departments and divisions, may really help with this. Secondly, knowing the resources and prior literature available allows you to build on existing knowledge instead of repeating it. And this sort of not reinventing the wheel concept applies more broadly to residency, certainly to research and innovation. but also to patient care. The best, or at least I think the most effective residents and interns that come onto plastics are ones that not only do they learn the patients beforehand, get some patient sign out, but they learn about the service, how the service is organized, and how you can be effective within the organization that already exists. And then I did want to include a caveat here, which is that you should always be thinking about how things can be improved and bettered, but just with a strong consideration to what is already available to you. So getting back to the case, surgery proceeded as planned. The picture on the left shows the flap elevated just prior to harvest, and then the picture on the right, you can see the disconnected flap now hooked up to the perfusion device. The flap was flushed continuously with pulsatile flow that was set at 61 beats per minute and a systolic pressure between about 90 to 100 over 60 to 70. The total pump time was 1 hour and 55 minutes. So one interesting aspect of the perfusion pump that we hadn't really considered beforehand was not only the ability to get pulsatile flow, but also resistance numbers from the pump. So you can see here, well, I don't know actually how well you can see it, but at the outset, once the flap was originally hooked up, flow was at 22 mils per minute, and resistance was pretty high at 3.63 millimeters of mercury per milliliter per minute. But these numbers improved over the course of flap perfusion to 83 milliliters per minute, and then a resistance of only 0.86, which suggests, of course, improving microcirculation within the flap, probably by decreased vasospasm. So if we sort of were to correlate this to the kidney literature, it might suggest that if we had just intermittently flushed or static cold storage for this flap, we might not have gotten the same effect. So once the external iliac artery and vein had been prepared, anastomosis took place without complications. After arterial anastomosis, the vein began bleeding almost immediately, indicating minimal clot burden within the flap. And then because the continuous perfusion also eliminated the buildup of waste products, we proceeded with the venous anastomosis right away without the need to let the vein bleed. So flap inset and immediate post-op course were uncomplicated. The patient was discharged to inpatient rehab on post-op day 17. Unfortunately, 2 months after surgery, she developed some locally recurrent disease. These were at the time of the biopsy. You can see some little asterisks there that ended up all being recurrent cancer. She also developed some lung metastases, and no further surgery was done, such that she expired about 5 months from her original surgery. The flap is that, here in the middle. So this case was a really exciting experience for me. It opened my eyes to the many potential future uses of extracorporeal perfusion. Our case represents the first time that resistance numbers were used to assess free tissue transfer. More experience with these numbers could really have a lot of utility to a microsurgeon. If there was data on what resistance numbers led to successful flap surgery, you might be able to better assess your flap takebacks to see if the flap is salvageable. I thought that would be really interesting. Andrew kind of mentioned this as well, but use of perfusion for therapy delivery is also like a very exciting and new topic. For flap surgery specifically, again for takebacks, it's the ability to take a flap out of the patient, put it on pump, and flush it with thrombolytics that aren't then exposed systemically could be hugely useful, but there's lots of other therapies you can deliver during pump time, both for transplants and for flaps. And then expanding indications for using extracorporeal perfusion, such as, where else, there are other areas that along ischemia time is found in plastics and microsurgery. Obvious corollaries would be replantation, and then also limb and face allotransplantation. So, exciting research is already being done in these areas, demonstrating extension of the allowable ischemia time in porcine limb models and also canine composite flap models. Clinical work is still a little bit in its infancy. There's only one published case series here of using extracorporeal perfusion for limb salvage. This was a 2-case series of amputated lower extremities. They were perfused for up to 16 hours prior to replantation with exciting but mixed results. One of the flaps survived but had a little distal ischemia, and then the other flap ended up with a venous thrombosis and had to be re-amputated. So exciting stuff, but as our mobile perfusion units get more savvy and technology gets better, the value and indications for this technology are very likely to expand. So this brings me to my next lesson, which is being present, or the value of different experiences in residency. This is something that I've really thought a lot about during my residency, because plastic surgery residency has changed really drastically in the time that I've been a resident. I'm the last resident to go through in the more combined model, which is 3 years of general surgery followed by 3 years of plastic surgery. And all the residents since me have done progressively less and less general surgery and more on-service rotations. And so the changes in our program are reflected nationwide. This is a mandate by the American Board of Plastic Surgery, and the reason for it, well, there's a lot of reasons for it, but mainly that there's a lot more to know in plastic surgery that needs to be covered, and then 2, the idea that the training that you go through should better reflect the future practice that you have. So it's a mandate, and things are moving in that direction. However, what's really still very unclear is what off-service rotations are needed to help build an ideal training program. There are some current recommended rotations. You can see in this chart. If you can't read it, I'll just read it for you. Acute burn management is recommended, anesthesia, dermatology, oculoplastics, OMFS, and orthopedic surgery. And these are the percentage of programs that are doing those rotations. And those are the only ones that the American Board of Plastic Surgery specifically discusses. There's even more variability when you start looking at what other non-recommended rotations are done. These are sort of other general surgery and off-service rotations. And it's really interesting because, so this last column here discusses the average number of months done by trainees over the course of their residency and those things, and it's really variable. So the average amount of time that people spend on surgical oncology is 2 months, but the average is, or the range is 0 to 5 months. And I just think that this chart is really interesting because as the different surgeries that we do in plastic surgery change, what rotations become valuable also kind of changes. So just some examples, transgender surgery is something that we started doing in plastic surgery. It's now covered by insurance. We talk about it a lot. And yet people spend 0 to 1 month on urology, which is a big part of transgender surgery. So is that a delay in what we need to learn? Or is that not a rotation that we need to do because you're getting that information in some other way? Same with transplant surgery. People spend 0 to 2 months on transplant surgery at an average of 0.79 months, but limb transplant, face transplant is a really diverse and growing area in plastic surgery. Are we limiting ourselves by not rotating there, getting exposure to the drugs used, which are going to be similar for whatever kind of transplant you're doing? And thinking about indications for transplant and sort of all the non-surgical, not the surgical steps, but everything else around the surgery that might be important. So how can you make like a value judgment about that without any data? There's no data that shows what training system is better. And honestly, if you really thought about it, it'd be hard to figure out what metrics to use. On the one hand, I would never have considered using a perfusion pump if I hadn't rotated through transplant surgery. But as all the trainees that have come after me get farther and farther in their training, it's very clear that they're probably going to reach levels of competency with plastic surgery procedures that I won't have. So how do you make a value judgment on that? And I think the answer that I've come to over time is that, at least for me, this is probably the wrong question to be asking. Trying to make a value judgment about the way you trained or the way other people trained is kind of a moot point. We all train the way we train, and it reflects the culture and the best thinking of the time. So instead, a better question is probably to ask, given that medical training is getting more and more subspecialized, how can we make sure that we keep cross-fertilization alive? So in reality, I do think that many opportunities do exist, although taking advantage of them probably becomes more predicated on the trainee's interest. So patient care, taking the time to fully understand the care and interventions being provided by other services can probably help you form new ideas about how to do better in your own practice. In surgery especially, keeping an eye out for case similarities and then trying to get exposure to the way that different specialties perform the same operation has a lot of value. And it's not to say that you can't learn how to do something from your own service at all, but maybe watching the way that burn surgery skin grafts a hand, or that ENT approaches a mandible fracture, might allow you to pick up on different approaches, techniques, and instruments. Like when Dr. Greenhall skin grafts a hand, he uses a finger trap, which is something that we don't do in plastic surgery, but is interesting, and potentially you could start to use it if you thought that it was going to improve your skin grafts. And his are great, so it might. Does, probably. Didactic education is also especially valuable for cross-fertilization in a major academic medical center like ours. Broader conferences such as this one provide a venue to interact outside one's own sort of silo of medicine, both in sort of a casual sense with people that you see here at conference, but then also with the presentation. You know, I can't say that I've gotten something out of every single grand rounds that I've been to, but often the ones that you take something away from are ones that, you know, you didn't think, and bring up something that you would never have gotten in your everyday practice. So I think that has a lot of value as well. So moving back to the case, we ended up writing it up as a case report and getting it published in the Journal of Microsurgery, which all happened around the time that I was interviewing for hand surgery fellowships. So when I interviewed at Stanford, this person on the screen, whose name is James Chang, he's the chief of plastic surgery at Stanford. He also happened to be the ASSH president that year, and he's sort of a very well-known and very charismatic guy. Asked me to tell him about a case, an interesting case. So, okay. I thought, like, I'll bring up this case because I can sort of speak about it. It's a little interesting, and then it will highlight some part of my resume, and that'll be great. I'll talk about this. So I gave him this little spiel about the case, and then he, you know, as always happens, he gave me a little look that was just like, what the heck were you just talking about? And said, well, like, why don't you just do microsurgery? Like, he thought it was like this ridiculous idea. And, you know, as criticism goes, obviously that's not that bad. So the example from this case is a little tongue-in-cheek. But I certainly had a lot to learn in residency about handling criticism or really failure of any kind at all. Which is not to say that I didn't fail a lot prior to residency, but I definitely did not handle it well. So, like, for some context, here's a picture that an actually kind of good friend of mine posted when we were in medical school of us as medical students. And here's where he tagged me as the crier. So.
Frozen yogurt, that's important.
Yeah. So I worry a little that this lesson is going to sound like a riff from a self-help book, but it was an important area of growth for me in residency, and so I thought it would be important to share. As I made this slide, I did realize that I was probably blurring the line a little between criticism and failure, which are not really equatable, although one does kind of suggest the other. So I would just say, take this lesson as it strikes you a little bit. Part one of the lesson is realizing that criticism is really a good and understandable part of surgical practice. You know, when medical students sign up for surgery and do their interviews, no one says that They go into surgery because they want people to criticize them. It's, oh, I wanted to learn a physical skill, or I wanted to have an active job. No one realizes that criticism is a huge part of surgery. But, we are in a very high-risk specialty where the opportunity for harm is quite high. And so accepting the fact that everything, criticism is understandable when the situation has to go right allows you to realize that it should really come with the territory, perhaps more than some other fields of medicine and certainly more than other careers. And I think realizing that is probably the first step to a healthier approach here. However, and this is really, I think, something that took me some time to learn, is that any critique should really be taken at face value and not overly catastrophized. Failing at doing something in the OR doesn't mean necessarily that you're a failure, or the fact that Dr. X or patient X didn't like you might mean that you did not act in a very likable way, but doesn't mean that you're not a likable person. Or like in this case, the fact that Dr. Chang didn't think much of my idea doesn't mean that all my ideas are dumb. And then once you realize the first two parts, it becomes a lot easier to look objectively at the critique and maybe get something out of it. And sort of working through it in a systematic way, you can say to yourself, well, what's the context and who's the critic? Are there non-modifiable factors related to either that have to be taken into account, like a very distrustful patient or a really terrible call night? And what's the lesson? And a lot of times this is just a linear conclusion. Like I need to have a better system for triaging consults. I'm always going to identify this vessel from this direction in this way, or like I need to talk to this attending earlier or listen better to that patient. And then finally, what's the response? Usually the response at that point is just learning the lesson. And I would argue that sort of the knee-jerk response to criticism is like denial or explanation or just feeling awful about it because criticism feels bad. But in changing your approach, the most common response is just learn the lesson if there's one to learn, and then move on. So the final lesson for this talk is that similar to the way that this talk wasn't totally about extracorporeal flap perfusion, many of the situations we encounter in residency are much more than they originally seem. And as an aside, I do have to give some credit to Granger Wong for this lesson. He has a lot of really delightful aphorisms that you will learn if you work with him, such as fight your tendencies, wanting a balanced life is just another way of saying that you're mediocre. And another one that he says a lot is that it's never about what it's about. And he can mean a lot of things by this, but what I really think he means is don't forget to look at the big picture. It's a nice picture of you that I found. The big picture looks beyond the steps of surgery to what you're doing to the patient as a whole. And sometimes those factors are obvious. For example, the fact that you can physically perform a tendon repair on a patient but is one thing, but the fact that the patient is schizophrenic and bipolar is another. And then most people would argue that you can't really do the successful tendon repair without also addressing their psychiatric disease. Sometimes the lesson's a little bit more subtle. For example, to be a reconstructive breast surgeon, you're not only signing up to say, I'm going to do, this certain subset of surgeries, you're also signing up to be the healthcare professional that's with a patient for the longest from the time that they're breasted to non-breasted. And I would say that your success and your enjoyment of the field is not just predicated on the former, but also very much on the latter. And then I would say that although Granger Wong may disagree with me, sometimes it is about what it's about. Sometimes a trigger finger is just a trigger finger. But the important thing is that a successful surgeon needs to know the difference. So in summary, I'm not advocating that these lessons are the only keys to success in residency and life. My suspicion, although I don't pretend to be an expert, is that success is probably due a lot more to non-modifiable risk factors like someone's ethics, someone's work ethic, intelligence, resiliency, and a lot of other things. But these are lessons that I learned in residency and that I hope you would find helpful. So Just to sort of recap them, the first one is to find a mentor, or the middle of the night phone call test. Don't reinvent the wheel, or also know your resources. Be present, or look outside your silo. Everyone is a critic, or have an objective approach to failure. And it's never about what it's about, or look also at the big picture. So I'll close by saying thank you so much to my co-residents, and to the faculty of the Division of Plastic Surgery, and to the entire Department of Surgery. Many of you have been important role models to me, surgical mentors, career mentors, and life coaches, and friends. And my gratitude really knows no bounds. So thank you. Thank you.
So, Kate, that was a fantastic talk, really spectacular, and we're really impressed that you made it through the morning. I know that Dr. Hiroshi was over there thinking, are we going to deliver her? So, congratulations. I think it was spectacular. I think, wow, what a perfect segue from sort of the interesting complications that we presented this morning to your conversation about, you know, it's much bigger than just the operation that we do. And what you're signing up for has so many implications. We have a few minutes, if you're up to it, I think, to take some questions. Questions or comments?
Dr. Brown?
That was a great talk. I really appreciate it. I'm also very curious because we were able to measure the resistance after your pump. And I'm going to email and see if we can get some of that vascular tissue from friends or from your group too, so we can sell each pump to express that. Also, just wanted to say that, like, listening to you talk reminded me of the first time I met you was when we were again trying to figure out why a patient had lactic acidosis, and we were all zeroed in on every possible thing. We were the only one in the entire ICU room who figured out that the patient had just gotten metformin contrast. We still talk about that.
Oh.
It's just a reminder that that you can make a contribution at any level in your career. A medical student, and often it's the medical student, and this is full of these examples, who isn't, you know, imbued with this is the way you're supposed to think, but who just asks the question. And that comes from and keeping that curiosity and that thinking alive is such an important part, as well as lifelong learning. It's really impressive. Dr. Wong, great.
Kate, that's a wonderful talk, and it's just a reflection of how delightful person you are. But you know, you mentioned that that our broad exposures give us a lot of answers, and that the answers are at the interfaces. There's a saying that goes that the opportunity of a lifetime comes up about twice a day. It's just that it passes us by, and we don't see it. So it's to your credit that you've had some of the opportunities to view these other solutions, but that you took the initiative to run with it. So that's a credit to you, Kate. And it's obviously been wonderful having you for all this time.
It's been wonderful being here, and for all your lessons.
All right, I'm going to close on that. Fantastic.